Uh, Hi, everybody here, and everybody on the internet. My name is Zarbin. I'm a professor in the Department of Ophthalmology at the Rutgers, New Jersey Medical School. Thanks for joining us this morning. Um, the audience who's with us basically is very familiar with the department. For those of you who are online who are not familiar, I'm going to give you a little bit of data about the department. As you all know, we're the only um, residency training program in ophthalmology that's based in the state of New Jersey, 9 million people. And uh, about 25%, last time I checked on this, of the ophthalmologists that practice in the state have some connection to this medical school. They either did the residency here and or they were students here. So the quality of the residency training program has a very, very big impact on the quality of our care that's delivered throughout the state of New Jersey. In fact, if you look at the composition of the New Jersey Academy of Ophthalmology, the leadership composition, a very significant fraction of those individuals were actually residents in this department. And it is a very, very good residency training program. We take care of everybody. We get referrals from throughout the state. I think it surprises people to know that about half of the patients we see in the department actually come from outside of Essex County. Essex County is the county that contains University Hospital in the city of New York. And that includes patients who come from outside the state, and even some patients from outside the country who are referred here for care. The doctors here are very, very capable people. Um, the average tenure of being here is more than 10 years. Uh, the people who are in the faculty here, for the most part, have been here for a very long time. And about two-thirds of the doctors are uh, every year nominated to be members of these best doctors lists. I don't want to overstate what that means. It's a little bit of a beauty contest, but it does say something about the respect that the people in the community have for people who are professors in the faculty. The Lions, for those of you online who don't know this, I know everyone here knows this, have given tremendous support to the department for a period that I'm aware of 50 years, more or less, actually a little bit more than 50 years, and a variety of different sorts of support. So support for equipment to do basic research like electron microscope, equipment to do clinical care like endoscopes, lasers, equipment, excuse me, to support research that we do. And we're very, very grateful to all for doing that. I know that that's a sacrifice that you're making on behalf of your family to support the work that we do. We appreciate it. As I mentioned before, we take care of everybody, and everybody needs, from people that are running Fortune 500 companies based in New Jersey to people that sit on the street, to people who are invested, everybody. And we're happy to do it. If I think about my own practice, about 20% of the patients are in the charity care system. I would think Dr. Iyer's practice is probably closer to 80%, something like that. So there's a lot of people who do not get eye care if you weren't here. So we're a very important um, element of the chain of care, sort of as a safety net for the state of New Jersey. And we get support from the state, which means from you and me, taxpayers. Um, but we're giving a lot back in return. So that's just a little bit about the department. I'm going to give a talk. There are going to be three of us speaking today. After me, Dr. Habiel, who is an Associate Director of the Glaucoma Service and Associate Director of the Medical Student Education Program. And then Dr. Iyer, who's the Associate Director of the Residency Training Program and also the Associate Director of the Retina Service. What I'm going to talk about now is research we've been doing. It's not even research, it's clinical care we've been doing. People that have very severe retinal detachment. It involves using a medicine called methotrexate. And, uh, and this really all arises because of work that was initiated at Harvard by a professor who, believe it or not, was a first-year resident when I was chief resident in Hopkins. His name is Dean, and he thought of the idea of using this medication to treat this very severe scarring disease called proliferative vitreous retinopathy. So I'm going to show you what our experience has been with this drug. Uh, in terms of the relevant financial disclosures, I was the co-investigator in the Algira therapeutic study, which actually was a phase 3 trial to test whether or not this drug is effective in the treatment of proliferative retinopathy. And although the drug, I think, was effective, the FDA did not approve its use. So we used this drug to treat patients with this severe scarring disease. We're using it off-label. For those of you who may not be familiar, I thought I'd show a little bit about the anatomy of the eye so you can understand what we're talking about. So this is just a schematic of the eyeball, and the front of the eye has the cornea, which is clear. It actually provides 2/3 of the focusing power of the lens. And then there is a lens, which, as you get, can become cloudy. When it's cloudy, affects your vision. We call it cataract. When you have a cataract, it affects your vision. You get artificial lens placed in it instead. Then there's this gel that fills the center of the eye called the vitreous humor. It's clear, but sometimes it gets filled with blood or other. And then there's the which is this very delicate tissue that lines the side of the eye. It has sort of the consistency of wet tissue paper, and it's neural tissue that's connected directly to your brain. Um, there's a vascular layer called the choroid that supplies part of the retina, the blood flow. And then that fibrous outer coating called the sclera, the part of the eye that you can see when you look in the mirror. And the connection between the retina and the brain is provided by the optic nerve. So that's the basic anatomy of the eye. And the center of the retina, called the macula, occupies 4% of the surface area of the retina, and yet that is where our high acuity vision comes from, 20/20 vision. Everything else is peripheral vision. And this picture I'm actually showing to show you that the retina lines the inside of the eye. That's the way it's supposed to be, just like wallpaper lines the inside of a room. But under certain circumstances, the retina can become separated from the eye wall. Then it's called a detachment of the retina. And when it's separated, then it's deprived of blood flow, and that's how people go blind from retinal detachment. Now, unfortunately, getting a detachment is bad, but it can get worse than that. You can have a detachment that has intraocular scarring. And you might be wondering why that happens, and I'm going to tell you in a minute. But what I want to show you here is that there are different degrees of scarring. Just like if you cut your skin, there could be different degrees of scarring. And some people with the slightest get terrible scars. They're called keloids. That's actually the same kind of problem that happens for some people in their eye. When they get a retinal detachment, they get terrible scarring. And that scarring disease is called proliferative vitreous retinopathy, or PVR. But even within the context of PVR, there are different degrees of severity. So the lowest severity is you just get pigment clumping in the retina. The next level of severity is you get the formation of membranes that cause distortion of the retinal surface, which we can see as surgeons folded in the retina. And then in the most severe level of scarring, you actually get very thick scar that causes folding of the retina that's very rigid. And you might be wondering why I'm worried about that kind of thing. Well, here, maybe you can imagine this drawing is showing you a detached retina that's got a lot of scarring. And I'm going to show you the detachment. You can obviously see the retina is separated from the underlying eyeball. But this is scarring that's causing central displacement of the retina. And this is scarring that's causing interior displacement and foreshortening of the retina. And that, in order to fix this problem, you've got to get rid of that scar tissue. Either you've got to prevent it from happening, or you've got to excise it surgically with microinstrumentation. And that's the folding that you can see in the retina as a result of the scar tissue contraction. Because the scar tissue isn't just fibrous, it actually has muscle-like properties in that it can contract. And if you were to look at the scar tissue histologically, you'd see that it actually has some of the same um, biochemical features that your muscle tissue has inside the cells. And that detached from the retina, you can see in an ultrasound. So you can use your imagination. This doesn't show you a direct picture of the retina. It shows you an image of the retina based on a reflection of sound waves. And that V-shaped thing is the detached retina. I hope that's sort of intuitive for you look. But this is what it looks like clinically when we look into somebody's eye. Um, and I took this picture from the internet, so I want to acknowledge that. But you see the folding of the retina. And this is, a bad situation made worse by the scarring. Okay. And these people are hard to fix. So what do we do surgically to try to address the scarring? Well, we try to remove the scar tissue, but sometimes the scar tissue is so tightly adherent to the retina that it's really hard to remove it. It's a little bit like getting crazy glue off tissue paper. So in order to release the traction, we might make an incision in the retina, which is what I'm showing up in the upper story. Excuse me, I want to go previous. In the left-hand slide, you see that little scissor, which is cutting the retina to release the anterior traction on it. And then once you've made that hole, you can see on the right side these little white dots, which are laser scars that we make as surgeons to make a very controlled scar to seal down the retina. So that's kind of what we would normally do. Sometimes you have to cut out a lot of the retina, as I said, because you can't separate the scar tissue from the retina. So the only way to get the scar tissue is actually remove the retina itself. So here on the right and left hand side, you can see we've made a laser scar here to stop bleeding when we make the incision with the scissors. And in the right side, you can see all the retina that's missing. That's called a retinectomy. And this incision is called a retinotomy. And those little white dots are the laser scars that seal down the edge of the retinotomy. And you'd think that that's brilliant, that would just be great. But the problem is that when you do stuff like this, you get scar tissue growth at the edge of the retinotomy, and it can undo everything that you spent a couple hours doing in the operating room. And why do you get the scar tissue? I'm not showing this slide because there's going to be a test, and I expect you to remember this. But if it feels confusing or complicated, that's good. That's the message of this slide. It's a complicated process, but what it involves in large terms is when you get the inflammation in the eye that's associated with the scarring process, you get released into the eye a lot of molecules that stimulate more inflammation and that stimulate cell proliferation. And so you get an influx of scar tissue cells. If you can imagine this analogy, there's a difference between a soldier and an army. Okay, a cell is like a soldier. Scar tissue is like an army of scar tissue cells. Okay, so you get this migration of cells that are going to become organized into scar tissue, and then these cells start elaborating scar tissue collagen. Like, if you've ever eaten a steak and you see the sinew, the white part, that's what we're talking about, the scar tissue collagen. And that's when you're in trouble because the next step is you're going to get contraction and the retinal detachment. So you could look at this thing and go, okay, we're going to block one or more of these molecules. Good luck with that, because that's a very complicated pharmacological approach to the problem. Or you could do something much simpler, which is to block the proliferation of the cells. If they show up and they don't organize, then you just have a bunch of soldiers. You don't have an army. And if you don't have an army, you don't have the scar tissue. So how do you do that? That's what Dr. Elliott figured out with Thomas Krzyzewski, who was a resident at Mass Pioneer. There's a medicine called methotrexate. And it's an inhibitor of DNA synthesis, so it can block cell proliferation. It also is anti-inflammatory. Actually, we already use it. We use it in ophthalmology to treat intraocular cancer. We use it to treat chronic inflammatory diseases. So this is just what's called repurposing of the drug to treat a specific disease, proliferative retinopathy, PVR. And it turns out that unfortunately, when you inject this drug into the eye, it only lasts for about 6 to 8 hours, which means if you're going to use it to treat a disease that develops over a course of 6 to 8 weeks, that you're going to have to do repeated injections of it in the eye. We know from studies that were done at the Mayo Clinic that the dose of 400 micrograms in a silicone-filled eye is a safe dose. Silicone is the oil that we put in the eye to act as an internal bandage. You could use it to lubricate the the uh, the tread on the treadmill machine. I mean, it's oil, but it's sterile, and it's a really good intraocular bandage, actually. So I'm showing you this picture to show you that the patients that get this treatment have to have a certain amount of resilience because they're not just going to get an injection in the operating room in methotrexate. They get an injection every week for 8 weeks, and then every other week for 4 more injections. Um, but it, but it's you'll see that it's worth it in a lot of cases for them to go through that. So we treat a lot of patients. I'm not showing you this to expect you to read any of it, but just to give you a sense of some sense of the range. Everyone from children to older, very old adults. Um, most of the people in this series had trauma, at 61% of them. Why? Because people that have trauma are the ones who are most likely to get the scarring disease. That's why. And the severity of PVR won't mean anything to you except that degree of severity, CA-PVR, is very, very high severity. So these are people, we're not just trying to hit softballs here. These are people that we know are going to have trouble having stable retinal reattachment if we don't do something specific to help them. And as a result of the severity of PVR, they've had these large incisions in their retina. So think of this. Their trauma, let's say it's a trauma patient, increases their risk of PVR. Then to fix their retina, we have to make a large incision in the retina. That increases their risk of PVR more. So these are now at super high risk for getting scarring disease. And then this just shows that we've followed it for a pretty long time, so we think we know whether it's working or not. The average number of injections is 10. They don't all get 13 injections for various reasons. It's a very good, before we had the methotrexate, we had about a 70% success rate, which is not bad. I mean, it's not perfect. Now we're in the 90s. It's a call to low 90s, something like that. So that's better. And when you get the scarring disease, you can have a very low eye pressure, and the eye will shrink and die or not function well. That's called hypotony when the pressure is low. So we were paying attention to whether these eyes actually got some of these complications. In fact, they have a lower risk of hypotony if they get the methotrexate. They do get complications from the methotrexate. The skin covering of the cornea become defective because of the anti-proliferative effect of the drug can actually affect the surface of the cornea. That can be a problem. Sometimes the cornea decompensates and becomes cloudy and needs to be replaced. It's hard to know if, actually, I think I do know, but in principle, I would say it's hard to know if they need the cornea replaced because of the trauma or because of the methotrexate. I actually think it's in part because of the methotrexate. And some of the eyes have had the oil removed. Okay, so those are the big picture. What about the vision? The vision is very modest in this series of patients, but you have to realize these are severely traumatized eyes. So if you look at and when they show up, 86% of the patients have light perception or just hand motions vision before they have the surgery. Some of them have no light perception vision. In some cases, we don't even know what their vision is. The post-operative vision is really pretty bad. When counting fingers, 1 foot. That's if you look at the average of everybody. I don't have to tell you how dumb it is to look at averages. If we looked at averages, I wouldn't even be standing here right now. The but if you look at just say ask yourself the question: does anybody get useful vision when you do this? The answer is yeah. About a fifth of the eyes end up with 20/50 to 2400 as their final vision. If that was your only eye, you could live independently of that. 20/50, you can read the New York Times if you were inclined to want to do that. If you look at the best vision, about a third of them are 20/25 to 2400. Why does the vision go from 35% getting something, what I would call ambulatory, to 22%? In part, it's because of the corneal decompensation. So, but that's fixable with a cornea transplant. So I don't do that as the end of the world. So I would say overall, it's pretty modest improvement. Now, there are people that lose vision, but they lose vision because of coincident comorbidities. So, for example, severe glaucoma or stroke to the front of the eye. Those are things that the methotrexate is not going to cause or prevent. So let me just show you, and I'm going to finish up with these four cases so you get a feeling for what we're talking about. So this first woman, she had infection in her eye coming from somewhere else in her body. She had surgery for that. The infection got cured, but she developed a detachment with light perception vision, and she had a total detachment with severe scarring. And it, she underwent the injections, ended up with vision of 1/200, pretty bad vision, but way better than light perception, and a low pressure. And she got 12 injections. She did get that corneal epithelial defect, but it got better. But here's her pictures. So preoperatively, I can't show you a picture of a retina because her eye was too screwed up to get a clear picture of the retina. But I do have the ultrasound, and I've shown you one before, and you can recognize that V shape that comes from the total retinal detachment that she had. And in fact, there's a closed funnel back here, which, for those of you who may be familiar with this sort of thing, shows that she had pretty complex scarring. But here she is at week 7, the retina's flat. There's a little bit of scar tissue, which you probably can't appreciate at this distance, pointed out by the arrow. But you can see the pretty significant scar tissue nasal to the optic nerve. But if you look superiorly or temporally or infratemporally or infranasally, you can see the difference between the scar tissue there and the scar tissue nasal nerve. That thick white scar tissue just isn't present anywhere else. That's the effect of the methotrexate. And here's another example. This is a 46-year-old woman. She had a chronic detachment with light perception vision, severe PVR, and by month 21, she was 2400 with normal pressure. She only needed 8 injections. And here she is preoperatively. Again, you can see that V-shaped retinal detachment of the ultrasound. By month 3, she's got significant fibrosis, that white material at the temporal margin of her incision. But everywhere else, it looks pretty good. And you won't be able to appreciate this most likely, but this picture in the lower left is showing you a very fine epiretinal membrane distorting the center of the retina, which is permanently damaged because of the chronicity of the detachment. But this is, believe it or not, a good result. This woman, it was a schizophrenic patient who had bilateral total retinal detachments. We don't know what her vision was, but we thought she had light perception, at least in this eye. And normally I would not operate on this patient, except for the fact that she was bilateral in this state. And I thought there was a chance that maybe she could be helped with surgery. So we don't, as I said, we don't know if she had light perception, but I think she did. She did undergo the surgery. And after surgery, she could actually walk around without assistance. And so I'm quite sure her vision has been improved as a result of surgery, although I don't actually know what her vision is. She only needed 6 injections. Here she's her preoperative ultrasound. You haven't seen this before. This sort of funny appearance is a total retinal detachment. There's the detached retina. But that plug at the top is the scar tissue collapsing the front of the retina together. And the cord is thickened, which is not a good sign. And here she is, it's month 6, her retina is totally attached. She has a little bit of scar tissue. And where the retinotomy was done, I said, really no scar tissue to speak of. And this is the last case I'm going to show. This is the worst scarring I've seen with methotrexate. It's a young boy. He was playing at home with his brother, had a knife in his hand, fell down the stairs, lacerated below. And he had the retina. He had the retina incarcerated in laceration site. It was a mess. And but he got the treatment and ended up being 2070. Let me show you his pictures. So here, before we operate on him, what you can see on the ultrasound, you probably all experts know it, recognize the retinal detachment. And that fuzziness underneath the detachment is blood under his retina. Now you won't most likely recognize what that arrow is showing you, but what it's showing you is the retina is being drawn into the incarceration site. And that picture in the upper right shows you the location of the incarceration. And this picture shows scar tissue at the site of the laceration. And here he is, month 4. And what you're seeing those white arrows point out is the area where I had to excise the retina. And here is where the scleral perforation was, very dense scar tissue. Now, as it turns out, the knife went in the eye and lacerated the retina 180 degrees away, did not perforate the sclera. That's shown over there. So you see there's much less scar tissue where there's no perforation. Now, I am not saying that you have to use methotrexate to get these severe cases to work. So this is the case of a 16-year-old boy who sustained a ruptured globe before we knew about methotrexate. And he underwent exactly the same kind of surgery that I've been showing you, a large retinectomy and so forth. It's still come well. And here he is, post-operative day 1. He's hand motion. By month 6, he's 2100. He has very little scarring at his retinotomy site. If I told you this person received methotrexate, you'd probably believe it. But he did not. Nothing. So you don't have to do this. But let me tell you, for every one of these, there's like 9 of these. This is what it usually looks like when you have a 360-degree retinectomy and no methotrexate. You see the scarring at the margins of the retinectomy, the tenting up of the retina, even have scar tissue extending out to the peripheral retina. So I think for the average person with severe PBR, methotrexate is a good idea. And I think it reduces the scarring at the retinotomy sites. I think it increases the chance for retinal reattachment, especially and particularly when you have a detachment that either has PVR or is very high risk of getting PVR, like trauma. I think it probably does reduce the risk of low eye pressure, which is very frequently observed in ISO severe PVR after you reattach the retina. But it can be associated with complications. And the most common one, which is in about, well, say 15% of the patients, corneal epithelial defect, which usually will heal if you treat it properly, but you have to pause the injections when you do that. Give it a chance to heal. You can get some scarring in the retina itself. I showed you a case of epiretinal membrane. That's called macular pucker. I do believe, and we haven't published this yet, but we're going to. I do believe that there is some evidence that increasing the number of methotrexate injections may increase the likelihood that you'll need to have a cornea transplant. However, I'm happy to tell you that cornea transplant can restore your vision. So I don't view that as an unmanageable complication. The other thing that's very important to realize is this is an abortive vacuum. Now, the dose that we're giving in the eye is 1/60th of the dose that would be used to treat any systemic condition. So the likelihood that these intravitreal injections would induce abortion or birth defect is very, very small. But nonetheless, it's a theoretical possibility. So if we're treating a woman, childbearing potential, any female actually, this is a discussion we have to have with the parents, with the family. And and you might say, well, what if it's just a young girl? Could it affect her ovaries? And the answer is, I don't know. And at that point, you have to have a very detailed discussion with the family, and they have to decide how they will behave. I think the answer to whether I would use it or not depends on a lot of variables we don't really need to discuss right now. So I'm not going to go into that, but I just want to make sure it's an issue that needs to be discussed carefully. Anyway, happy to answer any questions if you have any. Anybody have a question? Okay. My question
from the chat. Okay. The question that we received in the chat is methotrexate, would it be effective on dry macular degeneration?
No. Although I believe it or not, it's been tried for wet macular degeneration. So let me make this. So in dry macular degeneration, the tissue degenerates, sort of like our skin wrinkles as we get older. In wet macular degeneration, you have the growth of abnormal blood vessels under the retina, which causes bleeding and scarring and loss of vision. And people have wondered whether a drug like methotrexate, by inhibiting cell proliferation, could reduce the abnormal blood vessel growth. It's a very reasonable idea, and it wasn't shown to be successful. But there are drugs that are very good at managing this condition. All right, so let me introduce Dr. Iyer. Prashanth Iyer is the associate director of the Retina Service. He has a very busy and very, very complex retina practice. He's also the associate director of the residency training program, which is one of our key raison d'etre for being part of the medical school. So he has a very, very important set of responsibilities in the department, and we're really delighted to have a person of his skill and personality, character, be a part of our clinical team. So thank you so much. Now I need to get out of this. So, just great.
You have your. All right. Let me know when we're ready to go. You can begin. Don't worry about it. Okay. Hi, everyone. My name is Prashanth Iyer. I want to thank the Lions for all their support in our department, not only research, but also the care they provide for our patients. We see a lot of patients in the Veterans Affair in East Orange, and they always are so grateful for the support the Lions give. I want to thank Dr. Zarbin for the introduction and for his mentorship. I'm going to tell you a little bit about myself. I'm from New Jersey. I was born in Bayonne, New Jersey. I went to undergrad at Rutgers University. I went to Philadelphia for my medical school and training, and Boston and Miami for my fellowship. And now I'm back at Rutgers in New Jersey. So it feels like a big full circle moment for me. And I'm so privileged to be serving the patients in our community here. And this job is just very rewarding in that sense, as Dr. Zarbin had mentioned. A lot of us in medicine have a motivation for doing medicine. Mine is my sister. She was born blind. She was born without the eyeballs. It's called anophthalmia. And ever since I was a kid, I wanted to serve people like her. I wanted to cure her, but her condition doesn't have a cure. But serving people like her has been my motivation since childhood. And she's such an integral part of my family, motivates everything that I have decided to do and my family. So now my daughter also gets to interact with her and enjoys that action. And I enjoy watching it. So it's a little bit about myself. Um, I'm a retina specialist, as Dr. Zarbin mentioned, and us ophthalmologists, this is a great praise. It's a beautiful day to save eyes, and I think every single one of us in our department gets to do that with such privilege. As a retina specialist, I get to see the back of the eye, the retina. And so this is the pupil and iris, and as we put the dilating drops in our clinic, the dilation allows us to see the back of the eye. And so this is the retina, the wallpaper of the eye, and it basically processes everything we see and sends it through the optic nerve to our brain. So the retina is so important for vision. This is a schematic. As you can see, the retina is the back of the wallpaper of the eye. This is a picture of a normal retina. The retina is the only organ in the body that we can actually see. You can't see the brain, can't see the kidney, can't see the heart, but the only vascular organ we can see is the retina. And it gives us a lot of clues about our body. Like if there's anything, systemic issues in our body, we can kind of detect it through the retina exam. Not kind of, we can definitely detect it through the retina. So the retina is a really important organ. It's definitely gives us a lot of clues. So the theme of my talk today is I'm going to talk about body conditions, systemic conditions that you can see evidences in the retina. So this is a 75-year-old person with hypertension, high blood pressure, uncontrolled high blood pressure, comes into the ER with some vision loss, and we can see all this blood everywhere in the retina. What happened is the vein, central retinal vein, was blocked, and that led to leakage and bleeding in the retina as well as swelling. You can see there's not only a lot of blood, but there might be even new vessels forming on the optic nerve. That's not a good sign. That means that the eye is not getting enough blood flow and blood perfusion. So we were able to help this patient improve their vision through treatment. One of the treatments being injections into the eye. Um, this is a very interesting case. This is a 50-year-old with thyroid cancer, had radiation to their left side of their thyroid, and then developed something known as radiation-related retinopathy. You can see that the radiation had effects on the eye. It led to poor blood flow and the development of, again, new blood vessels and severe bleeding. This patient also received injections and is doing a little bit better with their treatment. Now, this is a pretty subtle picture. Like on quick glance, it looks like a normal retina, but you can see that there's a little subtle whitening around the center. It may not be that apparent, but it's a little whitening. This is a 75-year-old patient who woke up with subtle changes, nothing significant. They said they're missing a little part of their vision, um, and so looking at it very quickly, we might miss that there might be something going on. But we have an instrument in our office known as the optical coherence tomography, the OCT machine, and that machine, very briefly, what it does is it releases light, and the light bends with the mirrors and then hits the retina, and then different projections of the retina get reflected back into the machine, and the machine is able to give us a picture of how the retina looks, the architecture of the retina. And so that's just a very simplistic way of explaining this machine. And so the OCT machine showed us that there are areas of whitening, which means that there's some issue with the blood flow of the microvessels of that retina. So this patient essentially is having an eye stroke. We were able to catch this, send them to the emergency room. They were able to get a workup, and now they're on aspirin and blood thinners as well as anti-cholesterol medications. This was a stroke that we were able to catch and essentially save their life. So this is called PAM, but it's essentially a mini stroke. So this is a patient, this is the right eye and left eye. This is a 30-year-old patient with retinitis pigmentosa. Retinitis pigmentosa is an inherited disease that causes vision loss because of loss of the retinal layers. It leads to pigmentation. You can see there's deposits of pigment around the retina. And the center, the macula, as Dr. Zarbin was mentioning earlier, gets severely affected, with this patient losing vision progressively since childhood. There's a lot of clinical trials going on for retinitis pigmentosa. Gene therapy is going on where you inject medicine into the retina, which has gene therapy, which can help to possibly stop the progression and maybe even regenerate some of those dead cells. Um, this is a patient that I'm actually seeing currently in my clinic. We saw them in the emergency room a week ago. This patient um, has a kidney transplant. They had a kidney transplant, and now is immunosuppressed because we need to take medication to keep that kidney working. But because their immune system is low, it developed an infection, a viral infection. So what we had to do, this is the other eye. They came in with hand motion vision in both eyes. So what we did in the ER, our fantastic residents and I, what we did is we put a needle in the eye, took a little sample, sent it to our microbiology lab, and they confirmed that this was cytomegalovirus or CMV. That virus is really very severe and it's seen in immunosuppressed patients. We were able to inject antivirals. We're injecting multiple times. The vision is improving slowly. The vision's now count fingers. We're currently in our hospital admitted for IV antivirals as well. So they're slowly getting better. But this is one of the cases that I think retina specialists see like a couple of times in their lifetime, and we get to see it on a monthly basis. So this is one of the patients in our clinic. You can see all the blood and the whitening, which represents the virus that has destroyed the retina. This is an interesting case I saw in fellowship. This is a lady, a 70-year-old lady who came in with no health problems. She didn't see a primary care doctor. She didn't complain of any health problems, maybe a little bit of fatigue, but she noticed that her vision was decreasing in the right eye slowly. When we look there, we see there's this big yellow lesion on the top of the retina. Was this an infection? Is this an inflammatory response? Is this a cancer? We were not sure. We were really scratching our heads. So we did a full body exam. We also sent them to it. This is a picture of that lesion. You can see it's elevated. So we sent the patient to their primary care. We also noticed that on her scalp and her arm, she had these little bumps. So we sent to the primary care. We sent them to their dermatologist. Did a biopsy, and it came back that she had metastatic lung cancer that was in the eye. Also had lesions on her skin. So we sent her to the oncologist. The oncologist treated her. Unfortunately, by the time we caught this, it was too late. She had cancer all over her body. But what we see can really impact patients' lives. We can catch cancer. Um, this is another patient of mine who I'm currently seeing. She has systemic lymphoma. And the OCT machine, this was in April when I saw her. The OCT, I'm going to draw your attention to this layer here. This layer looks pretty normal, but within a few months, this layer starts to get these deposits. So this made me suspicious that maybe her lymphoma is affecting her eye. And so we did a biopsy. The biopsy didn't come back positive. It didn't come back with any useful information, but slowly she started getting these lesions that we were suspecting might either be the lymphoma or an infection on top of lymphoma. So we're currently still investigating what we've been injecting her with antivirals. Seems to be responding, but there's also suspicion that this might be partially lymphoma as well. We're still figuring out the next steps, but we work with other specialists like the oncologist to help this patient. We may do a biopsy of the retina to confirm, and we may even inject methotrexate, as Dr. Zarbin was mentioning. Methotrexate might help. It's a chemo medication, chemotherapy, and may help this patient's condition. I like this shirt. It says, "Having retina surgery is easy." It's like riding a bike. The bike's on fire. You're on fire. Everything's on fire. I experience this pretty often when we have really tough cases. I call Dr. Zarbin once in a while to get his opinion while I'm in the operating room. But it's definitely a lot of stress. So this is a retinal detachment. We were talking about retinal detachment in our last lecture, but this is called a giant retinal detachment. I just wanted to show you a video of what retina surgery entails. So this is a surgery that I did. You can let me actually rewind it. You can see here that the retina is flopping, is detached, and has this really big tear. Um, and so what we do is it's called a vitrector with vitrectomy. We we cut the vitreous, which is the gel causing the traction. It's pulling on the retina. So we cut the gel so we relieve all the traction. You can see I'm relieving all the gel on top of this flopping retina so it doesn't have any traction on it. So as I'm removing that gel carefully, I start to use laser to prevent any bleeding. I'll move on a little bit faster. So there's this medication, a heavy liquid called perfluoron carbon, and what it does is steamrolls the retina flat. And so what I'm doing is I'm injecting this perfluoron to steamroll the retina. You can see it pushes the retina flat. But we can't keep this liquid because it's toxic to the retina. So we steamroll the retina, and then once we steamroll it, we laser the edges so that the retina can remain flat. We put laser throughout the area where the retina is detached. And then we drain any fluid that's under the retina. And we add more laser, and then we exchange the perfluoron for oil. You can see this is the oil, silicone oil that we're injecting into the eye so that the oil can basically push the retina flat. It can tamponade. And this is how the eye looks during surgery. We're injecting oil, we're removing the air that's in the eye, and we're having an infusion. So that's just a quick surgery that I wanted to show. So I think people find it fascinating how we do surgery. This is one of those patients that Dr. Zarbin was talking about who would need methotrexate because they're very high risk for developing scarring. If they develop scarring, it would be a great candidate for methotrexate. Um, I'm going to end on macular degeneration. Macular degeneration basically is a condition related to aging, the genetic risk factors. And what happens is as you get older, the retina starts to thin, starts to not do the job it's supposed to do. It's supposed to remove waste products, and the retina stops removing that waste product, and so you get deposits known as drusen. This is an example of early to intermediate macular degeneration. When those deposits are on the retina, the blood perfusion starts to be affected. So abnormal blood vessels start to form, and those abnormal blood vessels start to bleed. You can see all this bleeding. They start to leak in different parts of the retina. You can see there's fluid in all the layers of the retina, and so this distorts the vision because there's so much fluid and bleeding. What we can do for this, as we were talking earlier, is we can do injections. This is not me. This is not my hands. I would wear gloves, but somebody decided to be brave and inject without gloves. But we put an injection into the eye, and that injection has medications to reduce the blood vessels. Unfortunately, it's not a permanent solution. It's a monthly solution, or we start to extend that treatment. But that treatment can really help people see better. And we do this. Every clinic I have more than 20 to 30 patients that we have to do injections on. And we teach the residents how to do them. So this is an example of an injection that we do for wet macular. So this is dry macular. This has become wet. Now there's another type of, and this is the injection. You're injecting medicine into the retina to help that bleeding. Now, the dry macular can become advanced dry, where the thinning just becomes so significant that you lose retina, and this is also a cause of blindness or a decreased vision in patients. We have an injection, a new injection for these patients. It's called. We have multiple injections, but basically what it does is it reduces the growth of that thinning in the retina. A lot of patients are on these medications for dry macular degeneration. This is for advanced dry. This is the newest medication treatments that we have in our in our clinics and in retina practices. So it doesn't reverse vision loss, but it helps to slow it down. This is all we have right now, but there's a lot of research on the horizon. So dry macular degeneration is looking really good. So just really quickly, I wanted to talk about the research I'm doing here at Rutgers. I look at my population is mostly diabetic patients, so I look at diabetic retinopathy. You know, diabetes. In diabetes, what happens is when you have a lot of sugar, sugar starts to damage the blood vessels. When the blood vessels are damaged, the blood perfusion is poor, and so as a response to the poor blood perfusion, the retina starts to produce abnormal blood vessels, which can leak, bleed, and scar. And so you can see there's a lot of abnormal blood vessels and scarring that happens in diabetics. Um, and so, you know, the way to really, the goal of diabetics is to detect those abnormal blood vessels. You can see over here. What we do in our clinic is there's a test called the fluorescein angiography. You inject fluorescein dye, it's vegetable-based dye, into the vein, and you inject that dye and then take pictures of the retina, and the abnormal blood vessels get highlighted by the dye, the fluorescein dye. It's very helpful. It's been used for many, many years, but it's invasive. There's a small risk of anaphylaxis or some kind of reaction. The dye is not comfortable. Patients don't enjoy getting stuck. If they're diabetic, their veins are probably and arteries are probably very hard to get. So a lot of complications to doing this test. As I mentioned, that OCT machine has another component called the OCT angiography. It's basically the light system machine that can detect the movement of blood vessels and can help with looking at the blood flow in the retina without having to be invasive. You can see that this is the OCT. It shows the center of the retina. Um, you know, when you look at the fluorescein and you look at the OCTA, it's pretty comparable. You can catch all the abnormal blood vessels with this non-invasive machine. This is something that I really not only enjoy, but really I'm committed to studying these machines, the angiography machine, because it's non-invasive, cost-effective. There's no real adverse effects, and you get really good imaging. There was a study at in Miami where they compared wide field fluorescein to the wide field angiography, the OCT angiography, and they caught about 99% of those blood vessels I'm talking about. So really, more proof that the angiography, the non-invasive angiography, is great. And what I'm looking specifically is the different markers of vision loss in diabetics. When you have this angiography machine, you can look at markers to look at non-perfusion. I'm looking at foveal avascular zone, vessel density, the fancy words to look at the non-perfusion and the way the vessels are in these patients. Um, and, you know, this is an example of the foveal avascular zone. It's the area that doesn't have perfusion in the retina, and I'm looking to see if it gets bigger or smaller in diabetics. But in essence, I really enjoy the research I do with my diabetic patients. Um, so with this, I conclude my talk. Again, I want to thank everyone for coming, and thank the Lions, and thank you so much. Oh, yes.
Yeah, I have none from the internet.
Any questions from the audience?
Prashanth, I have a question. Are you going to use artificial intelligence in the research that you do?
Yeah, that's a great question. Definitely, I think having automated ways to detect these abnormal blood vessels is the next step. We're actually doing a project we haven't started, but looking at AI ultrasounds. So what we're going to do is have system to learn how to read the ultrasounds and then give them new ultrasounds and have them read retinal detachments in the setting of blood in the vitreous. It's a long-term project, but we got an ultrasound machine because of that grant. And so, but in diabetics, in the OCTA machine, that's also another goal in the future for sure. AI is definitely taking over, and you should definitely, yes. Yeah, I think. Yeah. 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 I think when you're diagnosed with diabetes, you should definitely get an eye exam with an ophthalmologist, general ophthalmologist, and they'll monitor your retina. And if they see any kind of retinopathy, they'll send you to a retina specialist at that point. But a general ophthalmologist will monitor, make sure that your retina looks good, there's no abnormal blood vessels. When they see early signs, they'll send it to the retina specialist. And then if there's any complications, we can go from there. Yeah. Yeah. Say that one more time. Yeah. I think it's part of. I think insurance covers everything. OCT, I'm not positive. Yeah. 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 You should definitely follow with your ophthalmologist and yes. Yeah, of course.
We've already started.
Uh-huh.
With the AI that you were just discussing,
Mhm.
Do you have enough here to, or is there going to be?
Oh, definitely. We have patients.
Data?
Yeah.
Train-
Oh, for sure.
train the model?
Yeah, for sure. We have, you know, in my clinic, I see 50 patients, and I would say 80% are diabetic. Um, and we have clinic a couple of days a week. We definitely have the patient population, and we definitely have the technology. We have very enthusiastic med students who are very interested in creating deep learning modules, and so we feed those scans to the module, and then they're very good they're very intelligent. I'm trying to keep up and learn, and they've been great. Yeah. So we, I think ophthalmologists are very important and essential. So thank you so much. Say it again. Yeah. Able to hear me? How are you? Nice to meet you. Thank you so much. I enjoyed yours.
Thank you, Dr. Zarbin, for the introduction. So we've talked a lot about the retina today. Now I'm going to shift our focus to the nerve and the top. And the way I love to describe this to patients is that there are parts of your eye that are replaceable, that we can easily replace and fix. And there are parts of your eye that are irreplaceable. And to this day, for the most part, we haven't figured out how to regenerate retinal tissue, nerve tissue once it gets damaged. The best way I like to describe it is think of a car with a beautiful clean windshield. That car might look wonderful, but if the engine's not working and your battery you're not going to get anywhere. So your engine and your battery have the optic nerve, your retina, they both need together. They are one continuum. Your retina will come together with the optic nerve. Okay.
Well, they can hear you.
Your retina comes together with the optic nerve to communicate with your brain what you're seeing. So, a lot of glaucoma over the past century has shifted to the importance of early detection of glaucoma, because if we don't detect it early, we cannot bring back that vision. But there's so much that we could do if we detect the disease early. So a lot of my talk today is going to be talking about all the studies that we have to, and the advances that we have to detect this disease early, and the current research that we're doing to improve access to care. So what is glaucoma and what is this optic nerve that we talk about? Well, the best way I like to describe the optic nerve is it's a donut. Most people, there is no normal, right? But if we were to classify patients as normal versus high risk, we think of a patient that's normal as having a donut that looks like a donut from Dunkin' Donuts or Krispy Kreme, whatever you guys prefer. It should have a small central hole and dough going all the way around. Glaucoma is a disease in which the donut hole gets bigger and bigger and bigger over time, and that dough gets thinner and thinner over time. That dough is responsible for communicating between your eyeball and your brain. That's the nerve tissue. So if that dough is very, very thin or missing, then there's no communication, and those people develop blindness. Glaucoma is the #1 cause of irreversible blindness worldwide, and there's a reason for that. It is a sneaky disease. People have no symptoms oftentimes because it starts off in your peripheral vision. Our brains are wonderfully made. They are made to fill in blind spots when we have them. It quickly corrects blind spots. I think I saw this discussion with glaucoma patients one time describing what they see when they look at a brick wall. And the areas in which they had the blind spot weren't white, weren't missing necessarily in early disease, because what happens is that things just become a little bit dimmer or a little bit blurrier in that spot. So what your brain does is that it just looks brown there, but you might not see the fine details of the bricks. And if that happens far enough in your periphery, you're not going to notice it. So screening is essential, to pick up this disease. And we're going to talk about some of the risk factors today that should lead somebody to see an ophthalmologist early. So, the definition of a glaucoma suspect who's suspicious for glaucoma is someone that has a bigger hole in their donut, right? Because sometimes people are born with big holes in their donut, and that doesn't change over time. That's not glaucoma. Glaucoma, by definition, is a small hole that grows over time. So, someone who's born with a bigger, opening in the optic nerve, and that is at risk of losing visual function from glaucoma, in whom glaucoma damage is not clearly evident. So we don't really know how many glaucoma suspects are out there. We know that there's people with high eye pressures. There's about 3 to 6 million people with high eye pressures. That's a lot of people. And that number might actually be higher because one big eye study called the Latino Eye Study showed that 75% of Latinos with high eye pressures were previously undiagnosed until they recruited them in that study. So probably more than 6 million. So what are some of the risk factors for glaucoma? Well, this study called the Ocular Hypertensive Treatment Study helped us a lot with identifying these risk factors. And it helped us identify, who should we treat, who should we watch. So one of the biggest risk factors is having a high eye pressure. I will say that just because you don't have high eye pressures doesn't mean that you are protected from glaucoma. But the most common type of glaucoma is associated with high eye pressure. If you have a family history of glaucoma and you have normal eye pressure, it doesn't mean that you're safe. You should still be seeing your ophthalmologist at least annually, depending on what they advise. We know that African Americans have a higher risk of developing glaucoma. Like Dr. Zarbin mentioned in the beginning, we are kind of like an international practice. We see patients from around the world. I have a lot of Nigerian patients and Ghanaian patients with glaucoma, and I see their children develop glaucoma because they're aware of the disease. They bring their children in and have diagnosed their children even at 9 years old with glaucoma. Um, having an increased vertical to disc ratio. Um, how thick your eye is important. So people with, thinner corneas, the front of the eye if it's thin, people with a softer eye where the collagen isn't as strong, those were found to be risk factors for glaucoma. Having advanced age. So what are some of the things that we do to screen for glaucoma? We take pictures of the eye, we check the eye pressure, we check the thickness of the front of the eye. Um, this trial that I spoke of showed that treating glaucoma even before it begins, like let's say someone has a high eye pressure, and we start treatment, it could cut their risk of developing glaucoma by 50%, which is so powerful, right? So you've prevented blindness there. So I spoke a little bit about the softness of the eye, and this is the special machine that we use to test that. It's called corneal hysteresis. That's the concept of it, and we test it by kind of like puffing, putting a big air puff in the eye, and seeing what pressure it takes to bend the cornea in and make it come back out. So people that have lower, like a softer eye, are more at risk of developing glaucoma. There are additional risk factors, so we have to look at the patient, their whole health. Having diabetes, being nearsighted, having a low ocular perfusion pressure, which I'll talk about. But basically, that just means that your eye pressure is higher than your blood pressure for the most part. That makes it hard for the blood to get to your eyes. So like Dr. Iyer mentioned, we have to look at the patient as a whole because a lot of times things are very connected. So this is an example of a very nearsighted patient that developed glaucoma. So, good to know that it's important to get screening if you're very, very nearsighted. And you guys see that they have very large donut holes, almost undistinguishable. And because they're nearsighted, they have thinning of the retina around the nerve, which could make it a little bit tricky to diagnose and follow those patients. So what do we do when we meet a patient for the first time? Well, we try to gather as much data as we can as possible. And we try to take pictures of them at that point in time because we're going to take serial pictures throughout the time that we see them to monitor for subtle changes. So we ask them their history, we ask their family history, we review any old records they have from any outside providers. We ask them about medications that could, in some instances, increase the risk of glaucoma, like taking steroids for a long time. And we ask them about any ocular surgery they had in the past. So people that have had LASIK have kind of changed the front of the eye, the cornea, so it becomes thinner. The reason we care about that is because when we measure the eye pressure, that machine works based on kind of like a standard thickness of a cornea. So once you interfere with the thickness and you make it thinner, you might get a pressure that's artificially low. So we actually have to remember that and add a few points. Then we do a full exam, checking their vision, checking their eye pressure. We do something called gonioscopy, where we basically look at the drain of the eye. So the eyeball on the inside has a drain that's different than the drain that's on the outside that takes your tears away. That drain is thought to, in a lot of types of glaucoma, over time to become more rigid or have an abnormality, and that's why people's pressure goes up. Because fluid is continuously moving the eye, but the fluid can't escape the drain. So this is a picture of the drain of the eye. It's that lightly pigmented structure over here. This also helps us distinguish what type of glaucoma the patient has. Some patients have open angle glaucoma. This is a picture of an open angle, meaning I could just see the drain by using the lens. Other patients have something called closed angle glaucoma, where you don't see the structure, all you see is just light. So basically, their drain is closed. And the treatment is very different depending on what type of glaucoma the patient has. And then we look very, very carefully at the nerve. We look using special lenses after we dilate the eye, and we also like to take different types of pictures. We take photographs, like these are photographs of the nerve. They help us follow the patient over time. And we also like to use a special machine called an OCT, which Prashanth talked about. So this patient in this picture has a large hemorrhage by their nerve, and we see that a lot in glaucoma patients, especially patients with low eye pressures who still have glaucoma. So it's very, very important that we use those photographs over time to kind of follow that patient's trajectory and how controlled they are. Prashanth talked about the OCT machine, and just like taking pictures of the retina, it can also take pictures of the nerve. And what I love about this machine is that it's capable of noticing microns of a difference over the years. So it's such a powerful tool to detect early glaucoma and to follow patients. And basically what this machine does is it takes a picture of the donut and it measures the dough around each clock hour of the donut. And then it compares it over time. Every time the patient comes back once a year, we usually repeat the test, and we're able to tell if there's a change in microns of like the dough at each clock hour. A lot of glaucoma patients will have damage to the nerve before they ever have damage to their vision. So this machine is incredibly powerful at detecting early glaucoma so that we could intervene and start drops or do laser or surgery before the patient ever develops damage to their vision. The way we test the function of the nerve, so this machine, the OCT we talked about, it tests the structure of the nerve. The way we test the function of the nerve is through something called a visual field test. If you think about a really dim room in which we lower a light bulb, and that light bulb is very, very, very dim, the people that are able to say, oh, the light's on, those people have a very high sensitivity to light. And I keep increasing the amount of light until everybody can see it. That's the concept of the visual field test. What the visual field test does is it asks the patient to look at a central target somewhere in the middle, and then it shines different lights of different intensities in their peripheral vision. And it compares your ability to detect the lowest amount of light to somebody that's your age, your demographic. And it maps it out. So that test is able to tell us if the patient has a blind spot. However, that machine is very, very large, very expensive, and people in stretchers, people in wheelchairs, people with neck problems have trouble doing that test. They can't do that test. They can't sit in the machine. So I'm going to move on to talk to some of our research at Rutgers. Recently, there's a lot of new visual field machines on the market. And there are virtual reality visual fields that are basically small headsets. They could speak up to 8 languages. They speak Haitian Creole, Spanish, French, and basically you put it on and it guides you, it coaches you throughout the test, because the visual field test is very subjective and people get tired, they lose attention. So what we did is we wanted to compare how effective was that little machine that's much cheaper than the big machine that's the standard of care detecting glaucoma, and how effective is it at telling us if someone's glaucoma is stable or getting worse. This is one of my excellent medical students who's now a resident at Downstate. He graduated. His name is Roy, and he's demonstrating the use of this model. This particular one is called the PalmScan 2000. And we obtained it from grant support thanks to the New Jersey Health Foundation and the New Jersey Fund for the Blind. And basically what we found is that, they had similar mean deviation, which is a metric that we follow to detect if somebody has glaucoma and if it's changing. Um, they were similarly able to tell us when somebody had severe glaucoma, but the technology still needs to be improved to tell us if somebody has glaucoma, yes or no, when it's mild. So, that's something that we look forward to with this company and with other emerging companies because it certainly has expanded to care. Prior to this, patients with stretchers can get replacements. But thanks to this machine, we're some kind of what's going on with their visual function. And interestingly, because this machine is really got some AI in it, teaches you, it translates. We found that patients did a better job doing the virtual reality visual field, even though it actually took a few minutes longer. It wasn't faster than this standard machine. Currently, we have a newer model of the virtual reality visual field called the Radius XR, and we're kind of comparing it to this older virtual reality headset and the Humphrey. So we look forward to, publishing those results in the next few years. We're still in data collection now. So what do we do when we meet somebody who is a glaucoma suspect? Well, we decide what the follow-up is. If they're very, very high risk, then we follow those patients closely. We discuss which treatment options are available to them. Those treatment options could be something called laser trabeculoplasty that I'll talk about next, or different eye drops. Glaucoma is a very dynamic field that's always changing, and thank God for that because, say 60 or 70 years ago, all that we had is one or two eye drops. Now we have so many more drops. If somebody is low risk, then we can follow them, as needed. If somebody is high risk, we like to keep them close and see them at least every year or two. Our goals, our main goal is to preserve their vision and maintain their quality of life and detect it at the earliest possible stage. One big trial has really helped change the way we treat glaucoma. We're leaning more towards starting with the laser treatment first because we found that people that are treated with the laser first tend to need surgery less later on. I'll take any questions.
I'm gonna pretend I read from the internet, but
Sure.
it's me. My question with the cornea is, you mentioned collagen is somehow connected to that, no pun intended. Is there a way somebody could preemptively supplement their diet or do anything to stave off or improve the pressure?
So I will say there's nothing that we found that will change your collagen composition, not in clinical trials, but there are several things that you can do to improve your eye pressure, like aerobic exercise, walking, anything that pumps blood from your head to your brain, reducing risk factors that decrease the blood flow to the eye, like controlling diabetes, and eating like a healthy diet full of antioxidants, like greens, blueberries, things like that. Because a lot of research in glaucoma has shown a problem in mitochondrial or like the energy production in the eye is one of the reasons.
Thank you. I have one more.
Yeah.
The goggles.
Yeah.
That you're using, the 3D virtual goggles, are they? That's not an off-the-shelf item. I imagine there's software that's involved.
So
What is
patients can buy them. I don't know if that's your question.
No, I was wondering if it's something that's proprietary and they do have to buy it from somebody who does the software / hardware work or is it just something, it's a program off the shelf and goggles off the shelf?
You could buy it from their website, and I know they're selling it to patients, and a lot of patients are taking their care into their own hands, where they feel like they want to be monitored more closely, for example. So they purchase it themselves, and they have videos online to train you on how to use it. You do have to download a software, but you can do it on your iPhone.
Interesting.
I have a sort of strange question, Miriam. Is it still the case that the prostaglandin inhibitors are the first line therapy for glaucoma?
For most commonly, yes, due to coverage issues with insurance.
So here's the question. Do people refuse treatment because of the change in eye color, or do you even talk about that?
I absolutely do. Especially if somebody has hazel eyes or light-colored eyes or green eyes. Blue eyes, they're less affected. Brown eyes, like dark brown eyes like mine, they're less affected. I also talk about atrophy around the eyelid. You get your fat atrophies. So there's a lot of med spa clinics now, and people are trying to do the opposite by getting fillers. Definitely talk about all those things. But it is one drop a night, so people love that, and it makes your eyelashes long. So the ladies like that. The guys, not so much. But yeah. Yes.
I'm impressed with the machinery that doctors have to use for various testing. Is that machinery developed by doctors or is it developed by?
It's developed a lot of times. It's a multidisciplinary thing. It's doctors and bioengineers and things like that. To my knowledge, AI has not yet developed machinery, but I can certainly see it suggesting ideas now that it's becoming more prominent. All right. Thank you, everybody.
Don't forget to take that off. You don't want to go home with it. Please.
Yes.
We are
Yeah,
presenting,
that's
we are presenting Dr. Zarbin with this check, a similar check here, because we go through what we're doing. Kathy Corning talks to the doctors that are here today, and Dr. Iyer suggested maybe we could use the special NEDS study that they use, which compares all the different modalities that go through all the different hospitals across the United States. And it's a yearly thing that's updated to see if what we're doing here is also being done in practice and what the results are. Are we doing something better than them, or are they doing something that might make our treatment better? So we decided at our board meeting that we would make the donation. It might be 8 years, but it has to be board. So Dr. The check is coming in. Here's a picture of it.
Thanks a lot.
Oh, you look at your smile, trying to see his banana. Okay, and I'll do one more back.
Thank you. Thank you. Appreciate it.
Congratulations. Thank you. Thank you for all the presentations that you all have done. It's been fantastic.
Yeah. I just want to thank you all for being here online and physically. That question at the end, I just want to comment on it because there's an assumption on it. You'd think that if you had the goose that laid the golden eggs, you'd know that you had a valuable goose in front of you. That's actually not how things work. So the best example I can give of that is this OCT. So Dr. Iyer talked about the OCT machine. Dr. Will talk about the OCT machine. The OCT machine is a central device in providing eye care for patients. How did that actually happen? There was a guy at MIT, actually two people, who developed technology to make these images, which initially they were really good. lousy. But it took a doctor, a guy named Carmen Poliafito, to insist that this OCT machine would be useful in treating uh, uh, eye disease. And because of Dr. Poliafito's, the combination of his personality and his intuition, he got one of the major pharmaceutical companies to use this machine to study the patients in the course of conducting a phase 3 trial. I can't tell you how hard that is. It'd be like, we're going to invade Normandy, and some guy shows up and says, I want you to go to this beach over here. And they did it. But it turned out, because they did it, they discovered, yeah, this OCT machine was really useful. And once they realized it was useful, then it started getting developed to a very, very, very high level. So it's this interaction between doctors and engineers and scientists. It's that, what Miriam was alluding to, this team approach is absolutely essential for the continued innovation in medicine, not just in ophthalmology. And that's really how it works. And that's why innovations tend to start at universities before they make their way into the commercial world, because that's where you have this group of people with different skill sets coexist. They may not know about each other's existence, but they are all existing in the same place and time. Anyway, just wanted to... Anyway, thanks a lot for coming. I had a good time. Appreciate it.
The lead clerk organization several years ago now were the ones that purchased the portable OCTs that you use in your clinics and in your hospital. Dr. Habiel said you can't use that on some patients because they can't get to it and this sort of thing, to get out of bed or whatever. So they asked to do that, find one that would work. They told us what they wanted. We spent thousands of dollars to buy it. We keep hearing it's being used all the time. So.
Yeah, well, and I didn't mention it, but you probably hope you know, we do telemedicine screening. In fact, I'm going to go visit right now. We're doing a screening today. And we have a portable visual field machine as part of our screening process. So, in fact, just so you know, the telemedicine program here that we developed under the leadership of Dr. Ben Zirth and Albert Corey and Dr. Habiel, served as the basis for the telemedicine screening program that was piloted in Poland. And in fact, the Fulbright program sponsored this endeavor. And now they've shown it's successful in Poland. And it's going to be probably become a national telemedicine screening program in Poland. And it actually was the program that started here that served as the basis for Poland's ocular health screening program. So.
Thank you, Doctor. Anybody want to take anything with you? Pick it up on your way out. I don't see it. I was Friday. Thank you all. Check it. Make sure that